I'm Dr. Ahmed Lotfi. I'm a senior consultant obstetrician and gynecologist. I have been practicing in UK, New Zealand, and in the Middle East. My qualifications are MBCHB, master's degree, and MRCOG. This presentation is about obstetric hemorrhage after the second trimester. Vaginal bleeding occurring in late pregnancy, during labor, or after childbirth. This is the subject of this presentation. Antepartum hemorrhage, which happens after the second trimester and before delivery. Intrapartum hemorrhage during labor and before birth. Postpartum hemorrhage after childbirth and up to 6 weeks. Problems. Obstetric hemorrhage is an emergency and it could be life-threatening. It is major cause of maternal mortality. Often unforeseeable and requires immediate care. Causes. Antepartum and intrapartum hemorrhage can be caused by placenta previa, abruptio placenta, uterine rupture, vasa previa, which is very rare, cervical lesions, cervical tears, or ectropion polyps. Postpartum hemorrhage can cause by uterine atony, retained placental tissues, lacerations in the perineum, vagina, cervix, and uterus, or can be caused by coagulopathy. Placenta previa. It is an implantation of the placenta in the lower part of the uterus, whether partial or total, covering the internal os. Most frequent cause of late pregnancy bleeding. Can cause severe maternal and fetal complication and is an obstetric emergency. It is sudden, painless, bright red vaginal bleeding. Can lead to shock and anemia, soft, non-tender uterus, malpresentation or high presenting part. Fetal heart rate usually normal. Do not perform vaginal examination if you suspect placenta previa. Ultrasound, placenta implanted in the lower uterine segment. Distance from lower placental edge to the cervix has to be less than 5 centimeters to diagnose placenta previa. Do not delay care while awaiting ultrasound report. If you suspect it, admit the patient and continue her care. Management. Insert IV lines, cross-match blood, infuse IV fluids, normal salines, Ringer's lactate, insert urinary catheter, and monitor urine output. Monitor vital signs every 15 minutes. Treat shock immediately if present, and these patients should be managed in high-level facility, as usually these facilities will be needed. Management before labor. If profuse bleeding, unstable, immediate cesarean section. If bleeding stops and stable, admit and manage until 37 weeks, then cesarean section. Ensure during admission that there is blood available and anemia is corrected. Any minimal bleeding, hospitalize and monitor and manage until term. Management during labor, profuse bleeding, immediate cesarean section. If major placenta previa, cesarean section, even should be delivered by cesarean section before labor. If uncertain diagnosis, double set examination in theater could be performed to establish the diagnosis. If type 1 placenta previa and the delivery is imminent, arterial rupture of membrane, artificial rupture of membrane could augment labor, and a short trial of labor could be successful. Other treatment measures: transfuse blood if hemoglobin less than 7 grams per liter or the patient is unstable. Start antibiotics. Prescribe iron and folic acid daily for 3 months. Manage newborn appropriately, especially if the newborn is premature. This is a flow chart for management of placenta previa, which you can keep it in your records. Thank you. This is the end of the presentation